PRP a regenerative therapy? I'm sorry, but it's not. It is a signaling therapy at best. I'm Dr. Scott Martin. I'm an interventional pain doctor. I've been in practice for about 25 years. I've talked to conservatively 5,000 doctors over the past 5 years. When you talk to that many providers, you start to get a pulse for where the market is going and what's happening. Now, can anyone tell me the average number of deaths from NSAIDs on an annual basis? The accepted average is 250,000 deaths a year. How many people die every year from narcotic overdose? I'm not talking heroin on the streets. I'm not talking fentanyl on the streets. I'm talking about prescription narcotics. How many die every year from narcotics? Fewer than 100,000. The conservative estimates are 250,000 NSAID deaths a year. The realistic estimates are well over 1 million. Why? Cardiac, cerebrovascular, GI, renal, neuropathy, all NSAID induced. I was a voice in the wilderness trying to scream from the rooftops that there was misinformation. And because of that misinformation, people's lives were being harmed. And I was silenced very, very aggressively. The reason I start with misinformation is I just want everyone to understand what's at risk. What is the value of OA of the knee on an annual basis? It's $5 billion annually. $5 billion, right? So do you think Big Pharma has a vested interest in OA of the knee? You betcha. Do you think big hospitals have an interest in OA of the knee? You betcha. And every time you use a biologic and a patient doesn't have surgery, doesn't take scripts, doesn't go to the hospital, they're not getting paid. And that chaps them something fierce. Mesenchymal stem cell, right? Seemingly, this is what the entire regenerative medicine space turns on, right? Ooh, the mesenchymal stem cell, right? Are you also aware that 3 patients died in Q4 in Mexico from stem cell IVs? This is not the magic in medicine. So we're here to dispel the myths, all right? How many differentiated mesenchymal stem cells are there in PRP? Exactly 0. So is PRP a regenerative therapy? I'm sorry, but it's not. It is a signaling therapy at best. If I take PRP, what collagen-based growth factor is in PRP? Oh, only type 1 collagen. There's no differentiated mesenchymal stem cells in PRP. None. My articular cartilage is type 2 cartilage. My synovium is type 1 and type 3. My meniscus type 1 and type 3. I've got an injury in that knee. I'm going to give PRP. There's no differentiated mesenchymal stem cells. There's no colony-forming units that are fibroblasts. So what's the stemness of that product? What's the regenerative potential of that product? You can come to your own conclusions. Your body stops making type 2 collagen at the age of 25. You have exactly 0 ability to create type 2 collagen right now, today. But type 2 collagen is present in the articular surface of every single joint in the human body. It's also 90% of the nucleus pulposus. 90%. And our bodies stop making it at the age of 25. So if our bodies stop making type 2 collagen at the age of 25, is it any wonder that as we age, we get degenerative joint disease? Is it? Or degenerative disc disease? But wait a minute, Dr. Martin, there's stem cells in BMAC. There's stem cells in stromal fraction. That's true. There are differentiated mesenchymal stem cells in both of those subpopulations. The problem? These are grown trees. These are curly oaks. But I need a Douglas fir. And it ain't going to happen. You're not going to get type 1 collagen from stromal fraction or type 1 collagen from BMAC to make type 2 collagen. It doesn't happen. The trees are already grown, hundreds of years old. So if all of these have a pro-inflammatory response, do umbilical cord-derived products have something different? Well, as a matter of fact, they do. They work by way of an M2 macrophage response. They just happen to down-regulate IL-1 beta. They up-regulate IL-10. They up-regulate ARG1. They down-regulate inflammation. That's interesting. So not only do they down-regulate inflammation, which is the primary mode of pathology in 90% of the patients that you're seeing in your office, right? But they also have the meats. They have type 1 and type 3 collagen, a little type 2 collagen, more concentrated hyaluronic acid than amniotic fluid, 100 times more potent. And they have extracellular matrix. I use something that I coined the Martin triangle. Not an egomaniac, I just had to call it something. Function being at the top. Because I'm a physiatrist and a pain doctor, function is key. Inflammation is here. Collagenic differentiation is here. This triangle works this way. In this patient with grade 3, grade 4 OA, he's in my office because he's in pain. His function is trash. Why? Because he's got inflammation. This is why we say patients have an experience of pain. From an experimental standpoint, I actually use a combination of exosomes and Wharton's jelly. Why? Because exosomes powerfully down-regulate inflammation, extremely powerfully. And the first mechanism that I have to remodel in this joint is inflammation. If I can't remodel inflammation, I cannot encourage collagenic differentiation. Collagenic differentiation meaning the body's ability to repair cartilage at a cellular level. So if you can down-regulate inflammation in that joint, do they improve systemically? As a matter of fact, they do, because you can reduce focal and systemic sensitization. This is critically important. We say all the time, how are you feeling, Mrs. Smith? If Mrs. Smith's knee is better because we've down-regulated the inflammation in that knee, she's feeling better everywhere because we've down-regulated substance P and NMDA systemically. I down-regulate inflammation first. Then I use a biologic consistent with the pathology. If I have a joint with degeneration of type 1, type 2, and type 3 collagen, I'm going to use a more robust biologic. If I've got a ligamentous rupture, if I've got a strain of a tendon or a ligament, that's type 1 and type 3 collagen. If I want to do Prolo for that, or I want to do PRP for that, or BMAC for that, that's hot, that's fine, right? If you listen to a patient, they will tell you what's wrong with them. We are all so excited about regenerative medicine. There's tons of science, there's tons of literature, there's tons of opportunity for research. But at the end of the day, it's not about the MSC, it's not about type 2 collagen, it's about the patient. And the patient's sitting there telling you what the problem is. You simply have to listen. Our job first is to be medical providers. Our job first is to serve. No amount of medical education, no amount of knowledge, no degrees on the wall, no $400 flower arrangements in the waiting room replace your individual curiosity as a provider. Intellectual curiosity will trump talent all day long in every single office in the country. Because your curiosity will drive you to ask more questions. It will drive you to figure out what is wrong with your patient and not what is right with their credit card balance. And ultimately, the outcome has nothing to do with regenerative medicine, and it has everything to do with a patient's quality of life.